title implies, our aims are to identify characteristics surrounding COVID-19 vaccine hesitancy and trust in home health workers in New York City. And just so we're all on the same page, we're defining vaccine hesitancy as a delay in acceptance or refusal of vaccines despite their availability. So home health workers, they are healthcare workers who provide long-term care to patients with disabilities and other chronic diseases in the home. They include skilled workers, so these are like nurses, physical therapists, and also unskilled workers who are mostly home health aides. Home health aides, again, as unskilled workers, usually have lower education levels, and they are largely women of color who are working at wages near the poverty line. And just based on these demographics alone, we know from research that this does put them with a disproportionate burden of COVID-19 mortality and morbidity. On top of that, there we go. On top of that, there were a lot of very particular risks home health workers had during the COVID-19 pandemic. You know, they were working in an environment with very little control, someone else's home for extended periods of time. They often were dealing with limited PPE, limited disinfectants. And also, you know, we're not receiving the same support as other healthcare workers. They often voice not having good communication with their agencies or not even knowing if their patients were COVID positive or not. On top of all of this, they were very slow compared to other healthcare workers with vaccine uptake when the vaccine finally did come out. These are statistics from March 2021, so kind of that initial rollout of the COVID-19 vaccine. And you can see home health workers really lagged behind others. So with our study, we led 90-minute focus group sessions over Zoom with a guide that we developed based on the 5C framework for vaccine hesitancy. This is a validated psychometric tool that looks at the constructs of confidence, calculation, constraints, complacency, and collective responsibility as all factors that likely contribute to vaccine hesitancy. In terms of a sample size with qualitative research, we don't usually target a specific sample size because we're not doing statistical analysis. Instead, our study aimed to reach saturation, which is where we're hearing the same ideas, the same thoughts over and over again from each focus group. We recruited from home health agencies in the Bronx, in Queens, and then also a very large union, the 1199 union, that covers the whole NYC area for home health care workers. In addition, workers needed to have access to Zoom, and they also needed to be English speaking. So our groups were conducted between December 21 and July 22. Our transcripts were uploaded into qualitative software. We chose to use Deduce. This is what it looks like for those not familiar. In the bottom left, we have our codes. So the coders on our team, which one of them was myself, we went through and created a code book using the 5C framework and also just from what the ideas brought up in the groups themselves. And at least 2 members of the research team coded every single transcript, made sure, you know, they agreed on the codes. If there was any discrepancies, a discussion was had until the research members came to an agreement on how something should be coded. So I'm going to move quickly through demographics here. So we also collected a brief demographics survey. Most of our workers were home health aides. And as expected, you know, a lot of middle-aged women, women of color. Again, this is what we'd expect given the population we were working with. Interestingly, of those who answered the demographic survey, which is about 80% of participants, 100% said they did get 1 dose of the vaccine. But we know this actually isn't true because we included workers who had exemptions or workers on leave from their agencies who voiced this during the groups. So take that 100% as you will. And then about half of workers, you know, were kind of in that early group of acceptors in terms of at least the date of their first COVID-19 vaccine, and the other ones were spread out, kind of keeping in mind that September 2021 was when the New York City mandate went into place. So just quickly highlighting the main themes that came from our focus group analysis. So first slide here, just big themes that were factors probably contributing to vaccine hesitancy. Conflicting information came up a lot, hearing different ideas from different sources. The ever-changing information, especially in the beginning of the pandemic, really decreased confidence and trust in a lot of workers. In terms of other barriers or constraints, low health literacy came up a lot, which was as expected. But something a little less expected was conflict in personal relationships. So a lot of workers who maybe had spouses or family members who were against the vaccine were actually trying to convince workers to not get the vaccine as well, even to the point of encouraging them to quit their jobs and find another profession in order to avoid getting the vaccine. Vaccine mandate also came up a lot, this idea of collective responsibility, getting the vaccine for the greater good. Hesitant workers had a lot of concerns about the mandate, expressing a lot of fear over mental health and loss of autonomy. On the flip side, there were protective factors that came out as themes as well for encouraging trust in the vaccines. So personal stories and individualized outreach were very highly valued by our workers. Having a trusted supervisor or friend, family member with medical knowledge reach out in an empathetic way helped to convince some workers who were initially hesitant to get the vaccine in our focus groups. And then also another big kind of protective factor seemed to be getting COVID-19 or having a friend or family member contract COVID-19 and have the very serious consequence that did push a lot of initially hesitant workers to get the vaccine in our study population. So I'm just going to make it with the time. So this is one of the first qualitative studies looking at COVID-19 vaccine hesitancy and home health workers. And even though there was the mandate that really did push workers to get vaccinated, there's an ever-changing landscape. Mandates are being lifted. There's boosters that weren't included in the mandate. So, it's still very important to look at targeted interventions to address hesitancy in this vulnerable group. And it seems like per our study, having personalized yet consistent messaging, particularly by a trusted source to really address those unique concerns and etiologies while still relaying consistent evidence-based information is important. Again, this is a launching place for future research to look at such interventions. And this is my team. I just want to say a quick thank you, and thank you for everyone for listening.